Welcome to your review of post-traumatic stress disorder and acute stress disorder, brought to you by allceus.com. 50 to 90% of the population have been exposed to traumatic events during their life. Most individuals do not develop PTSD, but a significant proportion of them do. Resilience is the ability to negotiate psychological and emotional changes after a trauma exposure. There are a lot of different types of traumatic events that we can look at. One of the main factors that serves as a buffer to the development of PTSD or ASD is whether people have adequate social support immediately after the trauma. During the initial assessment, you want to screen for recent and remote exposure and the availability of basic resources, food, shelter, a sense of security. If they have a place to live but they don't feel safe there, that's not meeting their basic needs. For each exposure, you're going to want to assess the proximity. How close were they when it happened? If it was a tornado, were they in the house and their house was hit by the tornado? Was it their house and it was destroyed by the tornado, but they happened to be across town at the time? There are going to be some differences in how people respond based on their proximity to the traumatic event. Similarity. How similar were they or are they to the person who was hurt? If they aren't the direct victim, they can still be traumatized if they have similarities to that person. Helplessness. Did they watch something completely helpless and just have to see someone else get hurt? Or were they a victim and they were completely helpless to change their situation? Social support, as I mentioned. If there is adequate immediate social support, the prognosis is a whole lot better than for people who don't have that. And stressors within the past 6 months. If you take someone who is pretty healthy, pretty active, pretty happy, and expose them to a trauma, yeah, it's going to traumatize them. But they're going to stand a much greater chance of appropriately dealing with it than someone who has been exposed to stressor after stressor after stressor over the past 6 months or so. Those people are already tired. Their resources are already drained. And if you think about it, a lot of us have instances where we can say, oh yeah, this was a really crappy last 6 months or last year. It all adds up. It's not like something happens, you deal with it, and it goes away. It happens, you deal with it, but then there's a recuperation period where your body's got to readjust, your serotonin levels have to come back up, etc. And if the person has a history of mental illness, now that doesn't mean necessarily schizophrenia or some other psychotic disorder. If they have a history of substance abuse, depression, or anxiety, again, they're going to have a harder time successfully coping with any trauma that comes their way than more so than someone who doesn't have that history and has adequate coping skills and can deal with most stuff that comes their way on a day-to-day basis. Initially, you're not going to, quote, treat them and make them deal with their stress. What you want to do is stabilize them. Get them to the point where they can semi-function, provide supportive medical care, supportive psychiatric care. Again, this is not delving into the issues and looking at acceptance or forgiveness or whatever your approach may be. This is supportive psychiatric care to get the person through the initial crisis. Ensure the availability of resources, food, water, shelter, safety, and provide this in writing. Provide in writing the number of the local crisis center. People in crisis do not remember things that you tell them. It's just, that's the last thing on their mind to worry about, is remembering some phone number for some agency that you mention. Write it down. Preferably write it down and provide it not only to the patient but to a supportive person that's there to help the patient. And start conducting the initial assessment. Don't do a diagnostic evaluation until the patient is stable. Doing it on the scene, doing it the next day, you're not going to get a clear reading for that patient's baseline level of anxiety, depression, coping, etc. And if you start probing and poking and having the person recall the situation too soon, you may open a Pandora's box and overwhelm them. Clinical evaluation requires the assessment of re-experiencing, avoidance and numbing, and hyperarousal. So when you get to the point of doing a clinical evaluation, you're going to ask them, do you re-experience this event? Are you trying to avoid things that remind you of the event? And are you constantly on guard, waiting for whatever this is to happen again? Acute stress disorder occurs within 4 weeks and must last for a minimum of 2 days. PTSD occurs 1 month or more after exposure. So you're going to have a person who's traumatized, and within 4 weeks, they will probably show some acute stress disorder. Now, you don't have to have ASD to progress to PTSD, but it usually happens that way. It starts as ASD, it doesn't successfully resolve, and then it develops into post-traumatic stress disorder. Dissociative symptoms that you want to look for include a subjective sense of numbing, detachment, or absence of emotional responsiveness. If the person is just flat, when they talk about it, they pretty much compartmentalized it so they can recite it like they're reading a book, and there's very little emotion involved. A reduction in awareness of the person's surroundings. If they're just kind of clueless, you can tell that they're just on autopilot. This is a problem. Derealization, depersonalization, and dissociative amnesia. They have loss of a sense of whether it seems very surreal. It doesn't seem like it really actually happened. They're wondering if it was a dream. Or they have amnesic points where they can't remember everything that happened. When it comes to re-experiencing, we see this a lot in your average run-of-the-mill PTSD patients, but you also see it in people with chronic PTSD, such as law enforcement officers and people who work in the ER and people who on a daily basis tend to see the worst of what happens in the world. Recurrent and intrusive distressing recollections. Out of the clear blue, or with minimal prompting from cues in the environment, they'll start remembering these horrible things that they have had to deal with. Recurrent distressing dreams. I've worked with a number of law enforcement officers who will wake up just in a cold sweat and a panic from reliving things that they've had to experience on the job. Acting or feeling as if it were reoccurring. Getting into a place where, say, we're dealing with a law enforcement officer again. They're running code to a call, and it puts them back in that same situation, that same mental mindset of when this other trauma occurred. And intense psychological or physiological distress at exposure to stimuli that remind them of what happened. So say they witnessed a car accident where lots of people were killed, people were thrown from the vehicle, something completely horrific. They're on the highway again and they get in a traffic jam and stuff starts getting backed up. They start smelling exhaust fumes like you smell when you're in a backup on the interstate. That's enough to trigger a lot of people who have experienced some sort of horrific car crash into re-experiencing that situation. Avoiding thoughts, feelings, or conversations dealing with the trauma. Now, this is a very protective behavior initially. The person who goes through this trauma is not going to want to wake up the next morning and start telling everybody about it, even though everybody wants them to tell them about it. So help advocate for that person so they're not having to constantly relive what happened. This is very true for rape survivors, because it happens. They have to report it to, if they choose to call law enforcement and report it, they have to report it to the law enforcement officer that shows up. Then it's usually transferred to a detective, and they have to re-report it to a detective. And then it's transferred to the state attorney's office, and they have to go over it again with the attorney. And then if it goes to trial, they have to go over it again on the stand. So they're having to tell strangers about this event over and over and over again, plus their family wants to know what happened. Unfortunately, we can't get all these people together in a room once and say, all right, here's what happened. But you do want to advocate for the person with their significant others and say, you know, if Sally Sue wants to tell you about what happened, then that's her prerogative, but please don't bug her to tell you about what happened. She will in her own time. Other things that indicate avoidance symptoms are inability to recall important aspects of the trauma. Where were you when it started? What did the person look like? Now, we're talking important aspects, whether the perpetrator had a scar on his face or not, or blue eyes or brown eyes or green eyes. Those aren't important in the big scheme of things. Yes, it's important to identify the perpetrator, but specifically what happened is more important than specific characteristics. Feelings of detachment or estrangement from others. When people go through these events, it's very not normal. It's very traumatizing, and a lot of times victims will walk around for days, weeks, or even months, if you get into PTSD, not feeling like they fit in, not feeling like anyone around them understands what's going on or could possibly understand, which pushes away social support, which is the greatest buffering factor. So you've got a vicious cycle going on here. Hypervigilance includes difficulty falling asleep or staying asleep. If every time you fall asleep you have a nightmare about the incident, then you're going to have difficulty with sleeping. Likewise, if you were a victim of an attack in any situation, you're going to be less comfortable making yourself vulnerable by falling asleep. Irritability or outbursts of anger. When you're stressed out, when you're emotionally exhausted, you tend to be more irritable. And so little things are going to tend to set you off more. And it's also, for a lot of people, a socially acceptable way of expressing a lot of the emotions that they have towards the trauma. They divert, they sublimate to other activities. And it could be positive activities, or they could divert it to being angry and irritable and snippy all the time. And an exaggerated startle response. A lot of survivors of crime have a long period, maybe even years, where they have a semi-exaggerated startle response. You really don't want to pop out from behind a door and go boo. But in the early stages of PTSD and ASD, it's an extremely exaggerated startle response. Just about everything scares them, makes them nervous. They hear bumps in the night. In order to adequately cope with a trauma, people have to go through a grief process. They deny what happened. They get angry about what happened. They start bargaining, if this just weren't so, if I could take it back, if I could relive that day, what would I do differently? Depression. Okay, it really happened. I can't change it. I can't make it go away. And then hopefully they move to acceptance, where they integrate whatever happened into their reality. During the first 48 to 72 hours after a traumatic event, some individuals may be very aroused, anxious, or angry, while others may appear minimally affected or just plain numb. So people respond differently. Just because they're not crying, just because they're not angry, just because they're not whatever you expect them to be, doesn't mean it's not affecting them. They are dealing in the only way that they know how to deal at that current point in time, and or they may be dealing in the way that works best for them. As you move out of that initial phase and into ongoing treatment, it's important to establish a therapeutic alliance. Increasing understanding of and coping with the psychosocial effects of the trauma. Now notice we said psychosocial, not psychological. Psychological is the grief, the trauma, the anxiety, all of depression, all of that stuff. But the social effects, whenever someone is a survivor of a trauma, it impacts their life. They don't live in a vacuum. It impacts their relationships with the people that they already know. And many survivors reach out to other survivors and develop a support network of people who do understand, who have been there. But the whole impact on the way the person interacts with the environment, who they trust, how they act on a day-to-day basis, is encompassed in the psychosocial aspects of the trauma. Also, you want to evaluate and manage physical health and functional impairments. If the person is not sleeping much or sleeping fitfully, their productivity at work is going to go down, and their basic day-to-day functioning is probably going to go down. If they're experiencing significant anxiety, agoraphobia, or depression, their day-to-day functioning is going to change in comparison to how they functioned before the event. You won't be able to do everything, most likely. It's going to be something that you have to parcel out in a multidisciplinary treatment team. So it's important to have a physician that you can work with if meds are needed. It's important to have a case manager you can work with if the person is exhibiting significant functional impairments. Effects of a trauma are wide-reaching. We've been talking up to this point about the emotional effects. Mentally, when a person is traumatized or immediately after the trauma, people have difficulty making decisions, concentrating, thinking straight, just what you would expect. Physically, there's a lot of upset stomach, headaches, backaches, neck aches, lethargy, general restlessness, fatigue. A lot of people in crisis don't eat well, so there's weight gain or weight loss, changes in appetite. Socially, it depends on the person. Some people become extremely dependent and extremely clingy. Other people become somewhat withdrawn and isolated. And yet other people dissociate from old friends and just develop a whole new set of friends that they believe can better understand them. Spiritually, it depends on the person. If they have a faith in a higher power, they may use that in order to integrate what happened. They also may become very angry at their higher power. Environmentally, a lot of people in the aftermath of a trauma change a lot about their environment. They're trying to remove the reminders of the trauma. They're trying to feel safe again. And in the immediate time right after a trauma, a lot of people just don't have the energy to do the day-to-day housekeeping and the other stuff. So you may see that environmentally, some of those things go downhill for a little while. And that's okay if they're reusing that energy in order to strengthen themselves. Now, if they're not cleaning and they're not eating well and they're not taking care of themselves, they're, heaven forbid, not bathing for a long period of time. 1 or 2 days is one thing. 1 or 2 weeks, something completely different. So you may need to look at interventions at that point. Financially, this is all building on one after the other. If you have a person that is not functioning well, they're not going to function well at work, which is often going to impact their finances. Finances can be a huge source of stress. If they can't go back to work right away, a lot of people don't have a 6-month reserve that they can tap into in order to stave off having to go back to work until they're feeling more normal, as it were. Effective treatments for both PTSD and ASD include supportive interventions, group therapy, support groups, case management. Psychoeducation, help the person understand and normalize what happened, help them understand the stages of grief, what they're going through, and help the family, if they're willing to participate, or the significant others, understand what the person's going through and how they can make it better. Look at the strengths that they already have and help the family and the individual capitalize on those strengths. If the person does end up needing medications, SSRIs, antidepressants, tend to be the best first-line thing to use. Buspar can also be used for anxiety. Benzodiazepines like Valium, Xanax can be used, but they are also putting the person at great risk of abuse. So you want to make sure they don't have a history of substance abuse, they don't have a history of alcoholism, and if possible, work with the physician in order to minimize how long the person's on the benzos, because you don't want them to start having withdrawal symptoms when they stop taking them. If they have something just to take as needed until the SSRIs and or the Buspar kick in, that's a lot more helpful than just relying on Valium or Xanax alone. And opiates can be helpful for physical complaints if everything else has failed. Opiates tend to increase depression. In this particular population, that's the last thing you really want to do. Opiates are also very highly addictive. So again, if you have a person with a history of substance abuse, a family history of substance abuse, and they're in crisis, this is like the worst possible time to introduce a substance that's highly addictive. Let's think about addiction. Addiction, for most people, they're using a substance when their coping skills are overwhelmed in order to escape. This person is in a position where their coping skills are overwhelmed, and you're providing them a substance that allows them essentially to escape. So you're setting them up to potentially, now again, there's a huge portion of the population that won't have a problem with it, but there is a significant minority that will. Preventative measures are few and far between, but cognitive behavioral therapy beginning 2 to 3 weeks after exposure can often help prevent the onset of ASD or PTSD. A lot of survivors have very distorted cognitions about the event and about the safety of the world and about a lot of other things. There's some all or none thinking. There's a lot of polarization of people and grouping. So if you can get in there early and help them identify those cognitions that are going to be harmful and replace them with healthier cognitions, they're going to be in a much better place, and they're going to be much stronger and able to prevent the development of ASD or PTSD. SSRIs can help with all 3 of the PTSD symptom clusters. They're effective for treatment of other disorders as well. So if the person had depression or anxiety or substance abuse or an eating disorder prior to the trauma, the SSRIs are not going to hurt. Now you do want to be careful. There's the caveat of bipolar disorder. And with bipolar disorder, SSRIs can actually trigger a manic episode. So they're not a panacea, but they do help a lot for most people. They may reduce the clinical symptoms of PTSD or ASD and have relatively few side effects. Now, we say that with caution. compared to antipsychotic medications, yeah, they have relatively few side effects. But the first 3 to 5 days that most people take an SSRI, they feel like crap. They're dizzy, they're nauseous, they're constipated, or they have diarrhea, their stomach's upset, which leads a lot of people to not take the medication because they don't start to feel the improvement for 4 to 6 weeks. And the first week is pretty horrendous, as is when you're tapering off. So warn your patients ahead of time that you may not feel so well for the first 3 days, but if you can make it through the first 3 days, you're going to start feeling remarkably better. Warn them about sexual side effects, especially if they're going to be taking the SSRIs for long term. Inform them that not every SSRI works for every person. Some people do better on Zoloft or Paxil or Prozac or any myriad of PTSDs are out there. So you want to let them know that if this isn't doing it for them, you can change it, but let's give it a chance, because each time you take an SSRI, before you start the next one, you have to taper off the last one. And that is an extremely trying process for most people. You want to choose treatments based on the patient's age and gender, the presence of comorbid medical and psychiatric illnesses, the propensity for self-injurious or aggressive behavior, how long ago the event occurred, the severity and pattern of symptoms, the presence of distressing target symptoms, development of problems in psychosocial functioning, and pre-existing developmental or psychological issues. That's the long way of saying individualize the treatment. If the person's not depressed and not showing anxiety, then don't just automatically put them on an antidepressant. If they are a teenager, you don't want to automatically put them on an antidepressant. Much research has found that antidepressants, the typical ones that we use in adults, are in fact dangerous for children. Any comorbid medical conditions, diabetes, hypertension, hypothyroid, you've got to look at other things that may be contributing to the depression and may be being exacerbated by the person's stress. Diabetes, for example. When diabetics are under stress, it's a whole lot harder for them to control their blood sugar. So before you start saying, oh, well, let's refer this person out for antidepressants, make sure you know if there are any other medical conditions which may be causing the depression that may not warrant an SSRI. Psychological debriefing or single session techniques are not recommended anymore. They found these to be more harmful because you put a bunch of traumatized people in the same room not too long after the event occurred, and historically it's been to rehash what happened. It increases symptomatology for most people in the room. They appear to be ineffective in treating individuals with ASD and PTSD. What you can do is to have a triage assessment in a group setting to identify those who are in need of intervention, but don't have detailed discussions of what happened and about distressing memories and events. Have the people talk about what they're experiencing now. Are they having a hard time sleeping? Are they having a hard time in their relationships? Do they have a difficulty concentrating and focusing? You can identify target symptoms, and as a group they can normalize the symptom pattern for one another. In individual therapy, then you can talk about certain aspects of what happened. Supportive interventions encourage acutely ill patients to rely on their inherent strengths, existing support networks, and their own judgments of the need for further intervention. We don't want patients to think that we don't believe that they can do it, because many of our clients can. Many of our clients, even the ones who develop ASD, don't have to go on to PTSD and may not. Encourage them to use the strengths, use the tools that have worked for them before. This will empower them not only now, but in any future episodes of trauma that they may experience. Ultimately, you want to reduce the severity of symptoms, prevent any comorbid conditions from occurring, improve functioning, restore a sense of safety and trust, protect against relapse when the anniversary comes up, if the news happens to be covering it. Whatever may trigger a relapse of that event, you want to help them prepare so it doesn't hit them like a ton of bricks. Integrate the trauma into a constructive schema of risk, safety, prevention, and protection. Yes, there are certain things that happen that really, really suck. If you're a victim of a home invasion robbery, safety. Where does safety come in? A lot of people don't do anything that increased their risk, so how can they ever feel safe in their house again? And they've got to look at things that they can do, whether it be getting an alarm system, getting a dog, moving into the city or moving out of the city. Those things in and of themselves don't necessarily make them any safer, and they need to understand that it's going to be a combination of being aware of what's going on around them, having law enforcement come, and many public information officers can come out and do a safety assessment of your house. Are there dark areas that are ripe for criminals to break in? Are there areas that could use bolstering as far as security is concerned? Are there things that to a criminal just scream, please come invade my home? Law enforcement can help you look for those things to make yourself safer in your own house. Your treatment plan should focus on observable, measurable goals and objectives. Feeling better is not observable, nor is it measurable. What is going to change? If you woke up tomorrow and you weren't feeling this way, what would be different in your life? How would you be functioning differently? How would your relationships differ? How would your employment differ? How would your environment differ? What would be different? Let's have some observable things that we can say, okay, she's doing better because I can see that this has changed. Cognitive behavioral therapy targets the distorted threat appraisal process in order to desensitize the patient to trauma-related triggers. Not every semi on the interstate is going to run you off the road. Not every person wearing a hooded sweatshirt is going to mug you. These are the things in trauma victims that need to be dealt with. Stress inoculation training involves breathing exercises, relaxation training, thought stopping, and cognitive restructuring. And this goes all together. When a person who's been traumatized encounters a stimulus that reminds them of the event, the fight or flight reaction kicks in. Their breathing increases. They get tense. Then all of those automatic thoughts that are distorted start running through their mind, which increases their breathing and increases their fear and increases their fight or flight. So it's this vicious cycle. The first thing when a person encounters a trigger like that is to be able to notice that their breathing's increased. When that happens, they need to be able to slow their breathing down to get out of that fight or flight pattern. Work on relaxing and figuring out what triggered it. They may not know until after they get their breathing settled down. And then work on cognitive restructuring. This semi is not going to run me off the road. They'll repeat that to themselves. Or, I'm safe, that was just a tree branch brushing against the roof. They need to have specific things that they can say to themselves to normalize things that happen in everyday life that may have stimuli that are related to the prior event. You're not going to be able to plan for every possible thing that is going to set off the fight or flight reaction. So it's helpful to role play in session what sorts of things over the past week set off your fight or flight reaction. What did you tell yourself? Was it successful? And if it wasn't successful, if they can go back and say, I don't know what set it off, but I was driving down the road or I was in my bed and then out of the clear blue, I started to have a panic attack. Well, then the two of you can go back together and figure out what might have set it off and work on the cognitive distortions and strengthen any relaxation exercises and thought stopping that may have been necessary or may have been helpful. Psychodynamic psychotherapy focuses on the meaning of the trauma in terms of prior psychological conflicts and development. It assures patients that they will decide how deeply to explore the difficult feelings and events and normalizes their distress. So this is a lot more vague and sort of obtuse than CBT, but some people prefer to really explore the trauma and what it means to them and why they can't let it go, or why it's not bothering them as much as they think it should, or answering a lot of those esoteric questions. The therapist's reaction can make ongoing attention to countertransference of particular importance. We've learned in Intro to Counseling that countertransference can help us understand more what the patient is going through. So be aware of your countertransference reactions, work through those reactions, and when necessary or when appropriate, share what's going on with your client. Educate your clients about what to expect as far as emotional responses and physiological responses. Let them know that they're going to feel kind of sluggish for a few days or maybe even a few weeks, even if they don't develop ASD. It takes a lot out of a person. It's exhausting to go through a trauma. Talk about strategies for decreasing secondary or continuous exposure. I mentioned the news media before. I'll mention it again. If the incident occurred in their home, it may be prudent for them to go stay with a relative for a little while. Some people like to get right back on the horse and they refuse to be chased out of their own home. So it depends on the person in that particular situation what's going to work, because you don't want to say, no, I don't think you can handle that. Why don't you go stay with Auntie M? That disempowers them. If they want to go back there and they want to stay, then what can you do to help them make that a successful venture? Educate them on stress reduction techniques and the importance of remaining mentally active. Falling into a deep depression and sitting on the sofa watching Oprah is not going to help them deal. That's escapism. They need to focus on self-care tasks. Now, this doesn't mean getting down with a toothbrush and scrubbing the baseboards. This means bathing and eating nutritional meals and trying to get adequate sleep, but not staying in bed all day. And provide recommendations for early referral. If you start feeling depressed, if you start having panic attacks, if you start having symptoms of one sort or another, make sure the person has a list of a case manager, if you have one available, a therapist, which ostensibly is you, the emergency room, and their physician's number. Most people have a physician, but when it comes to actually finding a phone book and looking the person's number up or whatever, sometimes that gets overwhelming if the person's already in a stage of distress. Have them program it into their phone. It's the easiest thing. It's what I do with all of our doctor numbers, because each of my children has different doctors for different things, and I know I need to call the dentist, but then I've got to get up and find a phone book and look up the name and make the phone call during their business hours, and it gets to be an ordeal when it doesn't have to be, because you can just program it in or keep a list. If they don't have a cell phone, keep a list on an index card in their wallet. Treatment placement. Same thing as everything else. How severe are their symptoms? Is there comorbidity? Are they suicidal or homicidal? Are they functioning? And do they have support? When you're talking about PTSD and ASD, internet-based therapies have shown some effectiveness if the person is not suicidal, homicidal, or experiencing substance abuse or something else where you really need to get eyes on in order to assess physical well-being. Patients with serious mental illness have higher rates of abuse and trauma. They are the susceptible ones in our society. They're the easiest ones to take advantage of. Depression, substance abuse, panic attacks, and severe anxiety are associated with increased risk of suicide. So if your trauma survivor starts decompensating, you really want to be aware that they may attempt suicide because life as they know it was obliterated. Their sense of safety, their sense of trust in the world, and if they can't get that back, if they can't get grounding again, it's very tempting to just try to escape it permanently for many people. So do be aware that trauma survivors can be just as suicidal as anybody else. Family members of victims are not only secondary victims, but are also one of the major buffers. If you have a child that is raped or a child that is kidnapped, they are their primary victim, clearly. But the parents who have to support the child, the parents who have to hear what happened, the parents who have to help the child through, are also secondary victims, but they're the greatest buffers. So it's huge to make sure that they can deal. If they are ineffective and not functioning, then that child is just left out there flapping in the breeze. Same thing goes for adults. If one partner is victimized, the other partner is a secondary victim. The other partner is going to hear what happened. The other partner may have been there, whatever. But the other partner is also the one that is going to be relied upon for the most support. So that person also needs your interventions to help them stay strong, stay healthy, and stay available for the victim. A lot of times you'll have people who are in the midst of PTSD who start having aggressive outbursts. When we look back at why this happened or where it came from, we find that they have so much anxiety, so much fear that whatever it was is going to happen again. They tend to be at the ready, that fight or flight reaction. And this time they're planning to fight. It usually occurs in the context of re-experiencing symptoms. My uncle was in the Vietnam War. And to this day, you don't want to go in and try to wake him up because he'll take you out. If he's in a deep sleep and you go in and try to wake him up, he will come up swinging. That is not him trying to be mean. That is not him trying to hurt you. But he still has that ingrained pattern of behavior where he's sort of re-experiencing where he was for a brief moment. Techniques targeting symptoms may reduce aggression. So theoretically, if you help someone target the anxiety or the depression, target their cognitive distortions that make the current world an extremely scary, dangerous place, it may reduce their aggression to some extent. Early childhood trauma is associated with the development of personality disorders. And personality disorders are ways of acting, ways of perceiving the world that are pervasive. They just kind of permeate everything. Extreme child abuse is very often associated with the development of borderline personality disorder. Kids don't have the ability to cope with trauma. So it's important to do what we can when they're children to really help them work through anything that they may experience. Features of post-traumatic stress disorder and personality disorders may overlap, and PTSD may be masked by the personality disorder. Again, especially when you're talking about borderline personality disorder. So it's very important to do a differential diagnosis and look at that child's psychosocial history. Other related disorders include traumatic grief resulting from a sudden unanticipated loss. Somebody gets killed in a car crash, gets shot in a drive-by. The patient requires stabilization during traumatic grief. Distressing thoughts or a longing for the person, and a duration of at least 2 months. So traumatic grief is significant enough that they require stabilization. It's not something that happens for one day and just goes away. And it really affects, again, every aspect of that person's life. There are many causes for post-traumatic stress disorder. And early intervention is the key to preventing later developmental issues in children and also potentially preventing the development of ASD and PTSD in adults if CBT, cognitive behavioral therapy, is started about 2 weeks post-exposure. Strengths-based supportive interventions are the best first-line treatments for ASD and PTSD.